Welcome back, friends. So let us talk about the osteology of lower limb. In this we are continuing with the osteology of fibula. In my yesterday's preparation I was preparing for this class, and I have prepared this entire class for 2 hours, and at the end of the day when I wanted to put this on a Google Drive, I realized that somehow the record button which you are seeing on the top right corner next to that aeroplane symbol, the red one, that button has got turned off automatically without my knowledge. So at the end of the class I realized that the entire session has not been recorded. So again I am starting the same thing. However, I'll be using the same this good notes presentation which I have used for recording live yesterday. So I'll be scribbling over the same thing, and let us begin now. Fibula, the word fibula itself literally means pin or brooch, what we use. It is a safety pin what we Indians use in our day-to-day life. So here you can see, so it is, this part is what we call as a fibula, and this is the portion what we call as a tibia. So that's how the word literal meaning of fibula is. Now the fibula is the lateral bone of the leg. It is homologous to our ulnar bone of our forearm. It's a post-axial bone developmentally. That means when we say post-axial, means this is the bone which is belonging to your lesser toe side, that is the fifth toe of your lower limb, and it is a non-weight bearing bone. This bone do not take any part in the supporting the weight. So I can show you this image. You can see in this image that this is your fibula, and fibula is attached to your tibia, and it is not taking part in the knee joint formation. So thereby we call this bone as a non-weight bearing bone. Okay. So continuing, now then if it is a non-weight bearing bone, then why the bone is there in the first place? So it serves the function of providing attachment to various muscles and ligaments and the septa, intermuscular septa also, and interosseous membrane. So these are the structure which can attach to this, but then as far as transferring the weight is concerned, it is not doing the job. And other than that, the lower end of the tibia along with the lower end of the fibula, it forms a socket for the ankle joint. So that means it does contribute to the formation of ankle joint. So it is quite reverse of radius and ulna. There you see ulna at the lower end is not taking part in the formation of the wrist joint, but here the fibula is taking part in the formation of ankle joint. Now this is definitely an example of a typical long bone. So when we say typical long bone, it has got parts. So thereby you have an upper end, then you got a lower end. These are your posterior view in this side and the anterior view on this side, and in between you got a shaft. Now upper end is the head of the, also known as head of the fibula. So it bears a circular facet on its inner aspect. So the circular facet, which is now I'm marking with the red color, is meant for articulating with the lateral condyle of tibia to form your, the circular facet is meant to form your superior tibio-fibular joint. Tibio-fibular joint. Other than circular facet, it has got a projection which is coming from here you can see in this part where the arrow is shown, from the posterior and the lateral aspect of it, because there is a posterior view and there is a lateral. So from the posterolateral aspect of the your upper end of the fibula, you will see that there is a bony projection coming up. Now this bony projection is called as the apex or styloid process of fibula. So these are the two features what we notice to identify your upper end of the fibula. Now there is a shaft. The shaft is intervening between both the ends. The shaft is triangular in cut section. It is triangular in cut section, and when you cut it, you will have 3 borders and 3 surfaces are there. The borders are, there is an anterior border. You can see here there is an anterior border. And right opposite you got the posterior border, and on the medial side of it you have the medial border. It is the sharpest border. It is also called the interosseous border. So in this figure we can see that there is a, this is anatomical position. This line what you are seeing, this one is your anterior border, a parallel line which is passing next to it. Now that one is your medial border, and backside if you see this line which is going down, that is the posterior border. So these are the border. In the app again I'll show you these borders, and apart from these three border, it has three surfaces also between these border. Between the anterior and the medial border, you got the medial surface. Between the medial and the posterior border, you got the lateral surface, and between anterior and posterior border, you got the posterior surface. So here if you want to see between these two red line, we have our medial surface, and then we have the lateral surface. So lateral surface will be somewhere lateral to this line, so that's your lateral surface here, and posterior surface is the widest of all. So whatever we are seeing at the back, that is your posterior surface. So these are the features of the shaft: three borders and three surfaces. Now if you look at the lower end of the fibula, so here you got the lower end is flat because the upper end was round, and here lower end is flat. It is flat from the anterior to posterior. So anteroposterior, it is a flat structure, and the medial surface of it. So medial surface is the one which is facing your your tibia. So there you have a medial surface it is articulate with your talus, and medially if you go posteriorly and inferiorly. So posterior-inferiorly on the medial surface, you see here in this picture I am showing there is a depression is there, a circular depression is there. Now this circular depression is what we call as a malleolar fossa. So we keep our thumb in this, holding the bone vertically with the rounded end upper and the flat end lower, and the thumb in this posterior-inferior medial aspect of the malleolar process is what we call malleolar fossa. So this lateral aspect of the lower end is what we call as a malleolus, lateral malleolus. It is subcutaneous. This is we use for the tibia as a medial malleolus or tibial malleolus. So these are in brief about all the three parts of a long bone. Now this will help us to decide the side and anatomical position. So now side determination and anatomical position. So for side determination, as I told you, here you have to hold the bone in such a way vertically that your upper end, which we call head, should be rounded, and then your lower end should be flat anteroposteriorly, that should be held downward. And here in this case I also told you that posterior-inferiorly on the medial aspect, of the lower end, you should find a depression, a fossa called as a malleolar fossa is present. So we hold our thumb in this, and then the bone belongs to the side. So this is how we decide the side and anatomical position. Now let us move to the details of it. We'll talk the entire thing under two heading: what are the bony features of these bone, and what are the muscle, ligament and other structures which are attached to this bone. So we'll start with the upper end. Now, upper end, we already mentioned that it is a rounded end of the bone, and it is also known as the head of the fibula. So here it has got, the head of the fibula has got three features. So we'll study this osteology of this under three features. The first feature I already told you, it bears a circular articular facet. It bears a circular articular facet. This is the part where the facet is present. So here is a facet. This facet is articulating with your lateral condyle of the tibia to form your superior tibio-fibular joint. Then posterolateral projection. So that means if you come posteriorly and laterally, this is the posterior view you can see here. In the posterior view, if you come, there is a projection going upward. This projection is what we call apex of the fibula, also known as your styloid process. So styloid process, or your apex, is the second feature of the head, and this particular projection, bony projection called styloid process, provide attachment to two ligaments. One is fibular collateral ligament. It is also known as lateral collateral ligament. The other one is popliteal arcuate ligament. Popliteal arcuate ligament. So these are the two ligaments which are attached to this. So articular facet was making a joint, forming superior tibio-fibular joint. Then the projection from the posterolateral projection called stellar process or apex, giving attachment to two ligaments, that is fibular collateral ligament, also known as lateral collateral ligament, and your arcuate popliteal ligament. I'll show this again in the app. Then we have, there is a sloping surface on this side. The sloping surface here in this picture you can see on this side where I am using the green and putting a star mark there. So you see there is a C-shaped structure is there on the, it is sloping surface on the little lateral or anterior aspect of this. So this is the anterior view. So when we see the anterior view, so head of the fibula anteriorly is showing a C-shaped slope, and that C-shaped slope is giving attachment to muscle called as a biceps femoris. So biceps femoris attaches to the head. So thereby, to summarize, the upper end forms a joint, it gives attachment to two ligaments, and it gives attachment to one muscle. So that is a summary of your upper end. So let us go to the app to see these things. Okay. So that's a lower limb, and let us identify the parts here again in this case. Let me edit. Okay, so now you can see the upper green part, what you are seeing is the head, and the lighter green part which you are seeing between the dark green and the pink color, that light green part is the neck. I will talk about that in a while, but right now that the dark green part above is the head, then the intervening the pink portion, the entire pink portion is the shaft, and again lower down you see another green part, that is your lower end. So lower end you observe it is flat compared to the upper end which is more or less rounded. Now coming back to upper end we said it bears a facet. See, you see on this side it is bearing a facet on the medial aspect. So that round circular facet is for your superior tibio-fibular joint. And then in addition to this, I told you that you have a styloid process, which is you see this upward projection what you are noticing. The apex of this, if you consider that as a triangular, the apex, the pointed area is what we call as a, so this pointed area is the apex or styloid process. So this is now giving attachment to two ligaments. Let us see this one. So let me check if recording is happening. Yes, because yesterday it has not happened, so I don't know where it went wrong. Okay, so now we have to see which are the ligaments which are attached here. So I told you one is your oblique popliteal ligament, another is a fibular collateral ligament. So for this we will need other bones also. Okay, now here you can see this is the fibula and this is the lateral view. Now the small one which I am holding, that is your fibular collateral ligament. So if you isolate, you can make out it is attaching from the styloid process to the lateral epicondyle, also called as a lateral collateral ligament of the knee or fibular collateral ligament. Now next ligament we have the V-shaped ligament, what you are seeing. This one is arcuate popliteal ligament. So this one is arcuate popliteal ligament, which is again attached to our, you can see, to our fibula. So this is the second one we have. So these are the two ligaments attached to the styloid process. Next we said there is a muscle is there. You can see there is a blue color area is a C-shape area. Now that's your insertion of your biceps femoris. So this is how the biceps femoris tendon is attached. You can see here there is a biceps femoris, long head and short head both are attached to this. So Here only the tendon is shown. If you are interested to see the entire muscle, so let us see biceps femoris. Bicep femoris, yes, we got the muscle now. If you notice here, okay, you can see here, this is here long head of bicep femoris. From the ischial tuberosity above, you can see there is a short head from the linea aspera, from the back of the femur. Both head are combining and forming a single tendon, which is coming and inserting to the anterior surface of head of the fibula in a C-shaped slopy manner. So these are the three features of your upper end. So we'll continue now. This is about your upper end. Now let's go to the neck. So there are three features. There is upper end has got head and it has got neck. So this is the second part of your upper end, neck. Now neck is got, it is the construction. Like anywhere else, it is a constriction below the head, so which I have shown here in the green color in both the diagram. You can see there is a constriction on both the side. That constriction is what we call as a neck. Now here it is not giving attachment to any muscle or a ligament, but it is related to your neurovascular structure. So on your, if you see here, this will be your lateral side and this will be your medial side. So on the lateral side it is related to one nerve. So the nerve is called as a common peroneal nerve. So posteriorly and laterally we have a nerve called posterolateral nerve called common peroneal nerve. It is a terminal branch of sciatic nerve. And on the medial side you have a artery called as the anterior tibial artery. So let us see these two things in the application. So okay, so now we need a nerve here. So first let us bring the nerve. Now you can see in this picture, if I turn this back, that's the sciatic nerve. This thick nerve is the sciatic nerve, and which is dividing here and giving rise to, you can see that's your, this portion, it's small twig, that's your common peroneal nerve. It is also called common fibular nerve. You see the nerve, if you observe carefully, the nerve is, first it is lying posterior to the neck, then it is coming lateral to the neck, and at the lateral point of the neck it is actually dividing now. So if I go further, you will see the nerve is now dividing into two divisions. This is one division here, lateral, another division is here, anterior. So these are the two divisions. And if I multi-select this, the fibula, and let us see. Now you can see here, so that these are the two, something went wrong. Let me go back, what happened? Did I select something wrong? Yeah, that was something wrong I selected, not this one. Okay, so this now and this now, yeah. Now you see here, so common peroneal nerve is little posteriorly, then laterally to the neck, and here it is dividing into two divisions. One division in anatomical position, one is going anteriorly, other is going laterally. So this is here, anterior division is what we call as a deep peroneal nerve, and the lateral division is called as a superficial peroneal nerve. The division of your common peroneal nerve is happening at the neck of the fibula. This is what is important, because when we do this nerve, that time this will come as an important point. So common peroneal nerve lies posterolaterally to neck, and it is dividing into deep peroneal and superficial peroneal nerve. So deep peroneal nerve will supply your anterior compartment of leg, whereas superficial peroneal nerve will supply the lateral compartment of leg. This again will come later. So more we know, better it will become easier later. So now in addition to this, you also have, there will be an artery which is called as an anterior tibial artery from the popliteal artery. This artery will lie on the medial aspect of the neck. So this will be your popliteal artery, give rise to two branches. One goes posteriorly called posterior tibial. This one is an anterior tibial artery. So anterior tibial artery is related medially, and whereas the common peroneal nerve is related laterally. So let us see these things again. Now in this, if I put the artery back into picture, so that's the artery I was telling, and if I multi-select the artery also so that we can separately see this, so this one is your anterior tibial artery. Now we can see the one which is now changing the red color, that is, you see, it is lying in hand with your deep peroneal nerve, so their intimate relationship is there. So artery is lying medial and the nerve is lying posterolateral. That is what is the relationship of neck of fibula. So let us go back to our presentation, and so this finishes here neck of the upper end. Now if we continue further, we'll talk about the shaft of fibula. The shaft of fibula has got three borders and three surfaces, as we already mentioned. So there is an anterior border. So here you can see the line which is shown here. This is your anterior border, medial border, posterior border. So we'll talk about the anterior border first. The anterior border here, it is shown already, is being drawn as a black line, which you can see in the image. Now this anterior border is starting. If you look at the extent of the anterior border, if I mention the extent is from the anterior aspect of the head. You can see this is above H is written, that is the head of fibula. So from the anterior aspect of the head, the anterior border begins, that is the beginning. It keeps on going down, and somewhere when it is reaching your upper 2/3 and lower 1/3 junction, please notice where I am putting the hash now. At that point, it is dividing into two lines, an anterior margin and posterior margin, and between the two margin it encloses a small triangular area. This small triangular area is in continuation with the lateral malleolus of fibula. So this is what is here anterior border extent. Above it is a single line starting from the anterior aspect of the head of fibula, and below it, upper 2/3 lower 1/3 junction, it divides into anterior and posterior margin to include a triangular area which continue down as a triangular area as a lateral surface of the lateral malleolus. Now what are the attachments we have here? So throughout it extend, it gives attachment to lateral intermuscular septum. It is a deep fascia. Lateral intermuscular septum is attached to entire extent of your until it is a single line, it is attached to the anterior intermuscular septum. The part where it is dividing into anterior margin and posterior margin, the anterior margin gives attachment to the superior extensor retinaculum of the leg. You have a extensor retinaculum, flexor retinaculum in the wrist of upper limb, but here in lower limb we have got near the ankle. What is wrist to the upper limb, ankle is to the lower limb. Here we got more than one retinacula, so that is why it is called superior inferior extensor retinaculum. So out of that, the superior extensor retinaculum, the fibular attachment is to this anterior margin, and then the posterior margin also gives attachment to another retinaculum, and that retinaculum is called superior peroneal retinaculum. There is another retinaculum we have to the posterior margin. So one septum, intermuscular septum, that is anterior, which is helpful in dividing the entire leg into various compartments. Other one are two retinacula. One is the extensor, other is a peroneal retinaculum. Let us see these two retinacula in the application. Now let us remove all these, and we have to see the septum now. First I can show you the border. So where is the anterior border? On this picture, if you see, where is the anterior border? Now you see, this is the anterior border. Now I am touching it. Once I touch, it becomes pink. Sorry. Okay. Yeah, this is your anterior border. You can see it is starting from the anterior aspect of the head. This is anatomical position. Above you see it is starting from the anterior aspect of the head or neck there, comes all the way down and only problem with this application is it has not shown that it is splitting into two borders. So the split into two border is not being shown. Here it is only a single line is going down, but I told you at the junction of upper 2/3 lower 1/3 there is a split is happening into anterior and posterior margin. So that split is not shown in this application. Anyway, so now we need the attachment now. So first attachment is to the septa. So there is a anterior intermuscular septum of the leg on the right, because we are seeing the right fibula. Now you see here, if you can make out, this is again anatomical position. Above you can see that is a fibular articular facet. The entire line, if you want me to touch the line to show that it is coming from you can see it is attached. That if you see here now, you can see that is the intermuscular septa attached to the anterior margin. So one end is attached. It is something like this, wherein this is your transverse section of leg, this one is your tibia, and this one is your fibula. That's the interosseous membrane in between. So these are your anterior. So from here septa will go all the way here. So it is attached, anterior intermuscular septa attached from the anterior margin all the way to the deep fascia of the leg. So there, this way the fascia will go. One more will go from the posterior like this. So that is your posterior border from the posterior intermuscular septa going to the skin again, or fascia. So thereby you have one compartment between them, and this compartment is what we call lateral compartment or peroneal compartment of leg. Similarly, if you remember from the linea aspera, here also we have seen the partition which is happening medial, lateral and the posterior intermuscular septa. So that was with the tibia, but this is with respect to your fibula. So it gives anterior intermuscular septum. Other than the septum, we notice that the other things which are coming from your border, the lower part where it is splitting, then we had your okay, so this one what you are noticing is this is your superior extensor retinaculum of the foot or the ankle, you can see. So this is your attachment to the anterior margin of the anterior border, and it goes all the way, and it is inserting or attaching, other attachment is to the lower part of the medial surface of the tibia. This part I have avoided intentionally in doing in tibial attachment, because tibia itself is a very big bone. So this attachment I thought I'll do with the small bone like fibula. So that's your extensor retinaculum superior. So that's the attachment. Now there is a posterior margin back there and lower down, that is so much lower down here, somewhere lower part, somewhere here, if I somewhere in this part, this area, you will have the attachment of our superior peroneal retinaculum. So whenever we use the word superior, it means that is inferior will also be there. So let us go and see our other retinaculum. Now there you go, this one, see, this is the one. If you can notice here you can notice that there is this retinaculum which I am showing. See, that's here. Now this one is called superior peroneal retinaculum. It is also called as a fibular retinaculum, superior fibular. So that is attached to the posterior margin. So these are the two structures and one septum which is attached to the fibula. So that finishes our anterior border. Now let us go to the posterior border. Here I have shown in this, you can see on this side where I am putting the star, that is a posterior view of the fibula, and that black line which I have drawn, it has gone little outside here. It should be on totally at the back of it, but that's your posterior border, what we are seeing, this one. This posterior border is extended, it is again starting from the posterior aspect of the head. You can see it is starting from the posterior aspect of the head it goes all the way down and it is finally meeting with the posterior surface of the lateral malleolus. This is our lateral malleolus. Here the line has gone outside, but if we continue the line properly like this, you see it is going to this one. So that's a posterior aspect of the, or else I can rub this and I can draw it one more time. So from the posterior aspect of the head it starts. You see there is one line is there. I'm just following this line. Sorry, this is where it ends. I have missed the line here again, but that's your extent. The entire extent is giving attachment to only one thing, and that is posterior intermuscular septum in its upper 2/3. So no muscles are attached, no ligaments are attached. So we'll search for another septum here, and that septum is our posterior intermuscular septum. So this one is posterior. So what I do is I will first show you the border, posterior border in anatomical position. This was the anterior border. Right opposite, if I go totally backward, so this size, this is our posterior border, which is extending from the posterior surface of the head of fibula and all the way going to the malleolar process. And in this you can see our attachment, and that is your posterior intermuscular septum, right, the same one it is attaching. So that's your attachment. Okay, so that's as simple as this. So two are there. So I told you anterior will give anterior border to the anterior intermuscular septum, posterior border to posterior intermuscular septum. Interosseous border. So if you see here in this picture, interosseous border is also called as a medial border. It is the sharpest of all the border. Now if you see the fibula in your, take the bone in your hand, and you will realize that these borders are not so very constant. They are spiral, they are twisted. So that is the reason it is very difficult to find out. The only border you will be able to appreciate very well is the interosseous border or the medial border, because it is the sharpest border. Now interosseous or the medial border is just medial to your anterior border. Now if I use this, now you can see here I am using a magnifying glass. So here above you see, and below you are seeing the magnified image. If I mark here, you can see there are two borders are there. This one I told as a your anterior border, and there is a next to it one more border is there, this one. Now this border is your medial border or interosseous border. Two border, anterior border, medial border. Now between them, whatever that, this is the medial border, what you can see, the entire thing. So I can go, and if you see here in this, now you can make out in this figure which I have drawn, medial border is parallel border. It is lying parallel to your anterior border, and as far as the extent is concerned, again it is starting from the medial aspect of the head of the fibula. It goes all the way down till the lower margin, you see, of the, here you have an articular facet is there for the lower end of the tibia. So that articular facet, this is what we, so there it is ending. So now what this entire extent it is giving attachment to here, interosseous membrane. You see the interosseous membrane is attached to the entire medial border. That is why it is also called interosseous border. And this is forming your middle tibia-fibular joint. So superior was above there, and this entire shaft to shaft is your middle tibia-fibular joint, a fibrous variety of a joint. So okay, so this is about your interosseous border and interosseous membrane. Membrane is very clear here, so we need not see in the app again. So let us move to the next surfaces. There are three surfaces are there. There is an anterior surface, posterior, no sorry, there is a medial surface between your anterior border and the interosseous border. There is a lateral surface between the interosseous border and the posterior border. There is a posterior surface between the anterior border and the posterior border. So let us talk about the medial surface first. Now medial surface, it is between the medial and the anterior border. Now you see here, there we mention, you see here, this is here. If you see in this line, I said this is your anterior border. Please observe the triangle also on the top, and this one is your medial or interosseous border. Now between these two border, you can notice that there is a surface is there. So that surface which I am putting the star now, so that gap, that slit is what we call as your medial surface. So medial surface is present between your anterior and the medial border. It's a very narrow gap. You can see if we try to measure the gap between this border and this border, it is found to be 3 mm. See, it is very less than half a centimeter. So 3 mm is the gap. So now that is the medial. You can see now in the picture here in the red line, you can notice this, which I am now putting a box around it. See how narrow it is, and it is extending. So medial extend all the way from the top till down there. So that's your medial surface. Now medial surface here, I told you it lies between anterior and medial border. Now it gives attachment to your muscles. So there are muscles are there. So this muscle is giving attachment to extensor digitorum in the extensor digitorum longus in the upper 2/3. So if I show you another image, here you can see in this. So this is the muscle we are talking, extensor digitorum longus muscle, all the way, something like a toothbrush. In the upper area it is little big like this, lower area it is smaller, thinner like this. So in upper, the muscle is taking origin, if you see, it is in the upper 2/3 area. In the upper 2/3 you see the upper 1/4 area is total, whereas in the lower it is only on the one aspect of it. So to understand this better, here we can see this diagram. Please notice the diagram. Now here is a schematic representation. The extensor digitorum is taking origin from your upper 2/3. That total peach color toothbrush what you are seeing is the extensor digitorum. This extensor digitorum longus, extensor digitorum longus. So it is in your upper 2/3. In the upper 2/3, if you notice, in the upper 1/4 area, it is taking origin from, you can see the entire extent, whereas in the lower 1/3 area of the 2/3 area, it is only taking origin from the your posterior half of your middle 2/3 or 2/4. So this is your extensor digitorum longus. So in simple word, it is from the upper 2/3 of the medial surface. Then you have another extensor. Now this is for the digitorum, all the digits of your lesser toes. Then this dotted line which is shown now. Now this one is your extensor hallucis longus. It is for your greater toe, extension of the greater toe. So this one is taking origin from the middle 2/4. So that area which is the posterior half of the middle 2/4, which is left out. Then the lower 1/4 area bilaterally from one edge to the other edge, it is giving origin to a muscle called peroneus tertius. So peroneus tertius arises from the lower part of it. So here you see, out of these three muscles, the two muscles are extensor. One is for the digitorum, all your 4 toes, and one is for your greater toe, hallucis. That is the reason the medial surface is also called as the extensor surface, because here the extensor muscles are arising from it. It is also known as the extensor surface. So let us see this muscle in the application. Now here you can see we are looking at the muscles. First we will identify the medial surface. Okay, that's a medial surface there. Yeah, these are the 3 muscles. Yes, the upper one which I am selecting. Now that's, so this is yeah, sorry. Yeah, that extensor digitorum, here it is shown, again it is wrong. Here as per this application, it is only in the upper 1/4, but upper 1/4 is bilateral. So small stick should also come down. I was showing in the picture, so a small step should come down there. It is extensor digitorum. So let us see how the muscle looks like. You see the muscle, and you see here the muscle starts from there, goes down, and it is called digitorum longus. You see your second, third, fourth and fifth toes, it is going and attaching. It splits and attaching to your digits. That's why it is called extensor digitorum longus. Now you also have another muscle next to it. This muscle in the middle part is the extensor hallucis longus. This extensor hallucis longus, you can see here, it is starting coming down and it is going to the great toe. So you are able to lift the toe towards you. It is because of this. So here this is the extension of your great toe. You also have one small muscle here in the lower part. So this portion is called peroneus tertius, also called fibularis tertius muscle. So this is small muscle which you can see comes down from the medial surface, goes down to the little toe, or you can call the fifth metatarsal. So this is about here all the three muscles of the medial surface. So medial surface is done. Your lateral surface. Your lateral surface is between your interosseous border and the posterior border. So somewhere here the arrows which are showing here. And here it gives attachment to only two muscles. In the upper part you see there is one muscle called peroneus longus, which is in the upper 2/3, and the lower peroneus brevis in your lower 1/3. Two muscles are attached here. It is as simple as that. And let us see this inner application. So if you turn this more on this side, yeah, that is your peroneus longus muscle. Again here also it is shown as a small twig, 1/4. It should be the 2/3. It should come down, and this is a muscle. You see that's your muscle peroneus longus. It is in the upper 2/3 of the lateral surface. Comes down. See the tendon going deeper to the sole, and it is attaching to your base of the first metatarsal along with your a tarsal bone. Now this tarsal bone is your medial cuneiform. Anyways, okay. So that's your longus, also called as a fibularis longus. And in the lower 1/3 area you have the fibularis brevis or peroneus brevis, and you see that muscle again. And this muscle comes down and it is inserting to the base of the fifth metatarsal. So these are your two muscles coming from your lateral surface. So we are done with the lateral surface. Now this is the extensive surface. Here you see, here I have already done in this part of it. So what I will do is I will again redo this part, otherwise it will not make much sense. So I will bring this. Now posterior surface, what it does is, so in the upper part you will find a posterior surface is extensive. It is between, you can see here, it is here somewhere in the front will be your anterior border and back is a posterior border. Anyways, so here it is divided by a vertical ridge. It is divided by a vertical, upper 2/3 of it is divided by a ridge. So ridge you can make out clearly in this part. That is the vertical line. It is a sharp line after the interosseous border. If you see any sharp line, so that will be this line, and this line is called as, it is called as a vertical line, and this line has a name. Since it is running in the midline, it is called median crest. So that is the name of this line. So what this line is doing, it is dividing the upper 2/3 of the posterior surface into two areas. Now this part is what we call, this area is here. This is towards the tibia, so I will call this the medial area, which is concave. So medial concave area, and this part is your lateral flat area. That is a medial concave area and lateral flat area. So that is a division of your posterior surface in the upper 2/3 and the lower 1/3. Remember, the lower 1/3 you don't find any division there. So it is only in the upper 2/3. So there again, here we can see that upper part, the lateral area of the, here in this again upper 1/4 of the lateral area, this much, this 1/4, this gives attachment to upper 1/4 of the lateral area, gives attachment to soleus. So soleus is attached here, soleus. And when you come down there, so now lower part, that means the medial concave area and the lateral concave area below this. So if you see this 2/3 of it, this portion below this, so 2/3 portion of this one which I am putting now, that is your medial concave area. Now this is giving attachment to your tibialis posterior. So tibialis posterior is attached to this one, and whatever the area which is left out on the lateral side, it goes even little lower also. So this one is here flexor hallucis longus. These are the three muscles what we have here. So in this picture you can see here, so upper one portion there we got the soleus on the lateral aspect of the medial crest, and then the lower part, in the middle part, you got tibialis posterior on the medial side, the grooved area, whereas your flexor hallucis longus we got on the lateral side. So this is the entire part, and this portion you don't have anything because it's related to the tendon of your tibialis anterior. The green line, which is the crest, median crest, it is related to your peroneal artery. The peroneal artery gives a nutrient artery to the fibula. It is the largest nutrient artery in the whole body. So I'll show these three muscles in the application now. So we have tibialis posterior, flexor hallucis longus, and soleus. So we have also seen the soleus muscle has taken origin from the your tibia also. So that was a tibial head, and this is your fibular head. So we need the muscle now. Okay. So this is our soleus muscle, which is rising in the upper part. You can see it's big. The tibia we have seen, this was the tibial origin. The fibular origin is here. It is, see, that's here from the soleal line on the tibia, and that from fibula. Okay. And next muscle you see is your tibialis posterior. You see this one. Tibialis posterior also has arisen from your tibia also. This is the fibular origin. You see, that's your tibialis posterior. Sorry, this is wrong. Where did I miss? Yeah, this muscle. Yeah, that's the tibialis posterior. You can see it is even overlapping the medial half of the posterior surface of the tibia. So interosseous membrane, medial half of the posterior surface of the tibia, and the medial half of the posterior surface of fibula is giving origin to your tibialis posterior. You can see tibialis posterior coming all the way down and going to the sole. Multiple insertions are there. Now next muscle is here flexor hallucis longus. Now this muscle arising from your lateral half of your posterior surface comes down, and you see it is going to the greater toe. So when you pull this string, your greater toe will flex towards your ground side. So that is what we call as a flexor hallucis longus. So these are three muscles, and because all these muscles are, so here you have a flexor hallucis longus and soleus and tibialis posterior. All this they will do the action which is the flexion of your toes, or it is a flex. So thereby it is posterior surface is also called as a flexor surface because of the flexor muscle. So all the muscles which are present on the posterior aspect of tibia or fibula, they are all called flexor. That is a flexor compartment. So this is also called flexor surface. So three surfaces are over. Now let us talk about the lower end of the fibula. Lower end of the fibula, here main feature is we have the lateral malleolus. You can see the lateral malleolus is okay. So here you can see this is a lateral malleolus. Now there are four surfaces are there. So anterior surface, so let me put down this is an anterior surface, and there is a posterior surface, so this is the posterior surface. Then there is a medial surface, so this arrow is showing medial surface, and there is a lateral surface, so lateral surface is this. So these are the four surfaces which your lateral malleolus is lower end of the fibula is having. So the lateral surface will continue down as a lateral malleolus. So if you look at the anterior surface is rough. You can make out here there are some rough impressions are there, and it gives attachment to two ligaments. So what are the ligaments? One is called anterior talofibula. Talo is from the talus. Talus is a bone which will fit into the next bone which we are doing in the next class will be the skeleton of foot. So this is one bone which is fitting into this socket is called as a talus. So there is a ligament which is attached from the fibula to the talus. So this ligament like this what we have is what we call anterior talofibular ligament, and in the lowermost part of the anterior surface it gives one more, because below this you have one more bone. This you will be knowing in my next class. It is called heel bone or calcaneum. There is one more ligament which will come down and attaches to this from the fibula that we call as a calcaneofibular. So one is your talofibular, anterior talofibular, other is simply calcaneofibular. So these are the two ligaments what we have from the your anterior surface of the lower end of the fibula. Similarly, if you go on to the posterior surface, so here is a posterior surface. So posterior surface, if you go here, you can see there is a groove is there. Here you have a groove. If you can make out, there is a groove is there. Now this groove is meant for the passage of two tendons. So that is the passage of your peroneus longus tendon and peroneus brevis tendon. So these two tendons will pass through this groove. So that's what is the posterior. It is something like a dorsal tubercle of Lister of radius there. So it is a groove meant for two tendons of peroneus longus and peroneus brevis. That is on the posterior surface. Now if you see the medial, that was a groove. If you see the medial surface we have to see inside of this. So that is triangular. Medial surface is triangular here. It will be triangular area on the medial side. Here it is a triangular area, and that is bearing a facet for your to articulate with the talus. The lateral surface of the talus will articulate here. So this is a comma shape. If you see this is a articulate with the comma shaped talus. So that is a joint which is forming. Other than that, if you come in the posterior part of this one you can see here, this was your medial surface. Posterior part of medial surface, if you come here you can see one depression. So that depression is what we call as a malleolar fossa. So that's a malleolar fossa in the medial surface. And this malleolar fossa is giving attachment to again the ligament. So the ligaments are, one ligament is your posterior talofibular ligament. So that means the ligament between the talus and the fibula. Anterior was from the anterior border. Same way here you will have again your talus is as it is, and one ligament will come and attach to this that we call the posterior talofibular ligament. Then in addition to this you have also a ligament which will hold your tibia and fibula that we call as a tibia-fibular ligament. So that is also attached. So and upper part of the malleolar fossa will give attachment to your tibia-fibula, tibia and fibula. Lower part will give attachment to talus and fibula, so that we call posterior talofibular ligament. So these are the two ligaments. Thereby anterior surface, two ligament, that is your anterior talofibular and the calcaneofibular. And posterior surface is having only a groove for your tendons of your peroneus longus and peroneus brevis. Medial surface is triangular, which is articulating with the talus, and there is a depression called malleolar fossa, which gives attachment to two ligament. Above it is to the tibiofibular ligament, and below to the posterior talofibular ligament. And the lateral surface, this is the lateral surface, or this is the lateral surface. It is triangular and it is subcutaneous, and it is separated from the skin by a bursa. So we call that as a bursa of lateral malleolus. So let us see these things in the application. So we need now the ligaments are required. Okay, so I need to remove some structures here. This we don't need, these are not required right now. Okay, this is our anterior talofibular ligament from the anterior surface, one, and this is, I have to remove the peroneal. Okay, this one, the background you see, that is a calcaneofibular. So this one, if I do multi-selection, this and this, sorry, this one, and let us go to isolate mode, and you will see. So that's our fibula, and there's a lower end of the fibula, anterior surface of lower end. Here you see lower and anterior surface. I have to just twist it. These all come from the anterior margin. So this one is your talus, and this is your calcaneus, heel bone. So you see this ligament which is attaching from the fibula to the talus, you should call as a talofibular ligament. So since it is present in the front, it is called as the anterior talofibular ligament. And this is from the fibula to the calcaneum, and you don't have anterior posterior, so simply you call this as a talocalcaneal ligament. Sorry, fibulo, because it is from the fibula, fibulocalcaneal ligament. So these are your attachment from the anterior margin of lower end. Now if you go back, so if we hide this also, now we are done with these things. So let us now posterior surface. If you go, so you see the posterior surface, I am hiding the septa so that it becomes clear. Introsseous membrane also. Okay, if you see the posterior surface, now that's the posterior surface of the lower end of the fibula. Here you can see there are two tendons here, the synovial sheath you are seeing, but inside this you will have the two tendons which will pass. So this is the groove on the posterior surface. These are the two tendons. One is your peroneus longus and another one is peroneus brevis. So that's about the posterior surface. Now lateral surface is simple. So lateral surface is triangular and subcutaneous, and it is related to the bursa. You can see that is the bursa. This is the subcutaneous bursa of lateral malleolus. So when we sit on the floor with the folded leg to have food or to offer prayers, so this is the part which will come in contact with the ground, and this is the area which become darker also. So because this is the skin coming in contact, here you have the bursa deeper to it. So this is the bursa what we are seeing. So now medial surface. Now to do medial surface we have to remove so many structures now. So let us remove the tibia. Let us remove the other tendon which we don't need. So to see medial surface, here you see there is an articulation happening with the talus. So I am removing the talus also now. Now the talus has been removed. Okay, now you can see that's the area, and here this is your fossa called malleolar fossa. The rest of the triangular area is this one. So this triangular area will articulate with the lateral surface of the talus to form your talofibular joint. So that is the talus part, and this posterior and inferior area is your malleolar fossa. So this malleolar fossa is giving attachment to two ligaments, and There is one ligament here between the tibia and fibula, so this we call as a tibio-fibular ligament. And there's another ligament here, this one. It is your posterior talo-fibular ligament. So these are the ligaments what we see. So from the fossa above and below, two ligaments are there, and the fossa itself is called malleolar fossa, and in the front of the malleolar fossa on the medial side, a triangular facet for the joint with the body of the talus. So this finishes here lower end of the fibula also. So now we go to the presentation. So we are done with the lower end. Now as far as the ossification is concerned, it is of significance here. So we have not mentioned ossification so far until the last ossification we did in the lower limb osteology was the lower end of the femur, where it has got medical legal significance. So this also here we have some significance, and the significance is here we say the law of ossification. We have learned about the ossification. It is a process of bone formation, and it is governed by various laws. Now among many laws, 5 to 6 laws we have seen in the beginning classes. So one law says that the secondary ossification center, which appears first, unite last with the primary ossification center. So that is a law, but this particular law is violated in case of your fibula, which means the secondary ossification center which appear first and unite first with the primary ossification center. So it is appearing first and uniting first. This is what we call violation of your this particular law of ossification. So there is an explanation given for this. The explanation is there are two secondary ossification center, one for the lower end and another for the upper end. So lower end is, since it is making a joint with the tibia, forming superior tibia-fibular, upper end is making a joint with the tibia to form superior tibia-fibular joint. So this is called as a traction epiphysis, whereas the lower end is taking part in the formation of your ankle joint. So this one is what we call as your pressure epiphysis. So both the ends are different epiphyses. Another part which I also forgot to mention, that the nutrient foramen is directed downward where the nutrient artery is entering. So thereby your growing end is the upper end. So growing end is the upper end, which is your traction end. So because of the difference of these two types of epiphyses in the nutrient foramen and the growing end, this particular law is violated in case of your fibula. So that's about your ossification. Now moving to the, this is what I told you about the pressure epiphysis, growing end and all. Next is the applied anatomy. So this is a common source for the bone grafting. So wherever the bone is required, extra bone, that bone is taken from here, because this bone is not involved in the weight transmission. If you remove the bone from here and put it elsewhere in the body, it doesn't cause any problem there. And usually the bone is taken somewhere here. You do the cut here in the upper 1/3 and lower 2/3 junction at both the areas, and this middle piece of the bone is taken as a graft. And here, since it is weight bearing, so here they will pass a screw. So a screw is passed here in order to hold this in place, and upper one will remain as it is, and this middle piece is removed. Later on what happens, this bone, wherever it has to be used, usually it is used in the your avascular necrosis of the head of the femur. They will take this out along with the artery. So whatever the artery which is in the nutrient artery, the largest nutrient artery is the supply to the peroneal. So with the artery they take this piece out, and this piece will be used elsewhere with this nutrient artery intact, and it will help in growing of the bone there wherever we are putting it. And what happened to this part of it, this part may grow slowly eventually over a period of time, and you may have again back your fibula. A new fibula may grow in this area. So let us see. Now this is what is your avascular necrosis in the ball of the hip joint you are seeing in this area, and a tunnel is made in the your greater trochanter. This is the tunnel you can see, so that we can put the fibular graft here. And you see the number 2, figure number 2. Here we can see a small piece is taken with the vessel along with it, and it is, you see the vessel is still intact here, and a fibular graft is put inside this, and it will take care of this necrosis. This is, here we are using the fibula bone graft for the head of femur, where the head of femur has underwent avascular necrosis. This is another picture showing, you can see here, that is a proximal osteotomy line, nothing but the proximal cutting of the bone distal cutting of the bone. A screw is fixed for the lateral malleolus to provide stability to the ankle joint. And you can see with the artery, that is a nutrient artery, that is peroneal artery, is along with that you have taken the entire piece. This is what we call as a fibular graft with the artery is taken, and same thing is inserted by creating a tunnel in this. You can see here that is a harvested fibula in the tunnel, and this is the artery which is going inside this peroneal artery, and it will take care of. So this is how the bone grafting is done. The second applied aspect is the fracture of fibula. So your upper 2/3 and lower 1/3 junction is a point where the fractures are more common again here in this part, and there is not only fracture, these are also even associated with the dislocation of the ankle. So this is an associated problem. So this is everything about the applied aspect. I have one more figure is there, I think, where we can see the growth of the, you can see in this particular figure. So let me take this figure to the next page. Now here you can see here in this case what has been done. This is a fibula has been cut. You see here the fibula has been, so it is the A is here. So normal fibula is there, and here in figure B we have done the osteotomy at upper and lower end, and the fibula is taken for the grafting. We have removed it, and then after that you see in the figure C and figure D, over a period of time a new bone is growing, because upper and lower end are meeting and a new bone you have. So this is again what happens to the area where the bone has been taken. Fine. So here you can see there's epiphyseal lines or growth plates are seen. That means it is a growing bone still. So this is all about the fibula. Hope you have enjoyed it. If you have any question, get back to me. Thank you guys.